My name is Dave Lunsford, and we're doing a small demonstration this afternoon of a request from a prior student who took the course, and that is for pearls about frame application. And what we're talking about is the Lexel Model G stereotactic frame that we use for a large portion of the cases that we do gamma knife radiosurgery on, especially for patients who are going to have a treatment time of more than about 30 minutes. For patients who have any form of claustrophobia and won't tolerate a mask very well, or for patients who have targets in absolutely critical locations. That might be, for example, near the optic apparatus in some way where we really need to rely on precision. And of course, in most patients, this is going to be done in a single procedure. Mark here is one of our team members, and he's volunteered to be our test patient today. I told him that we're not going to give him any pre-anesthesia, and we're not going to give him any local anesthesia, but we're really not going to actually attach it to his head, even though he was nice enough to volunteer to take one for the team if we needed to. With me also is Dr. Agarwal, one of our senior residents in neurosurgery, who spends time on the course. So in our patients, we normally set them up as in this position, in a semi-sitting position, for the patient to be comfortable with the back supported with a pillow. We want to be able to have access to their head for application of the frame. And we start with preparation with the patient. We typically do give them subconscious sedation beforehand, and that starts out with a patient coming in early in the morning. And for a early start, we have them come about 5:30. We often give them a 1 milligram sublingual Ativan. But that's not going to really be enough to make the frame application really quite comfortable. So we then supplement that with intravenous kinds of sedation, using midazolam in titrated doses and fentanyl in titrated doses, which is based on patient comfort, patient's blood pressure, anxiety, and things like that. So it varies with the patient. The goal is patient comfortable in a procedure in terms of frame application that may take a few minutes only. So it's important that preparation is done in advance. Now, one of the things that we want to do in setting up the room and the patient for this is to have all of the equipment that we're going to need for the frame application. That is the pen for application, the posts for attaching the frame to the patient's head. We're going to have the anesthetic agent that we're going to use, usually local anesthetic. We usually tend to use a long-acting medication with a short one in the syringes, xylocaine for immediate action. But we set the patient up in a room like this, and we're going to want to have a picture of the patient's problem in the room. And we're going to have identification that we have the correct patient for the procedure that we've planned. And in a typical frame application using the Lexel G frame, we always put the nose bar down. And the reason for that is, even though sometimes the demos and the company information will show it going up, that actually sort of interferes in the patient's view to some extent. And so we always put it down. Now, the typical frame application is going to have 2 long posts in the front and 2 posts in the back that are straight. The front posts are somewhat angled. All of the posts will have a specific plastic insert in them that are designed to minimize any eddy currents that may occur during an MRI scan. So, as a general concept, we put the frame on with high bars in the back, and that's more comfortable. And the reason is because we have to anesthetize where the pen is going to go. Then with just having anesthetized the scalp and the pericranium is relatively fast, relatively quick, and relatively painless. If the target is in the front of the head, by the front of the head I mean sort of anything anterior to the sella turcica, or the pituitary gland, then that's going to increase the chance, especially very far frontal. Now we're talking about Y coordinates on the anterior part of the frame at 150, 155, 160. That's going to mean that put the gamma knife target into the focus of the gamma knife, which is fixed. What we're doing, of course, when we're doing a treatment is we're moving the target into the focus of the gamma knife. And that focus is fixed. But if this target is up here, we're going to have to drop the frame down. And if we have not used a short bar in the back, then it's going to collide. So in order for us to place the patient's head, we start out using ear bars. Not every center does, but we find it does several things. It provides symmetry, and it keeps the head still temporarily until we can actually attach the pins. So what we do is we move the ear bars back until we get to about posterior of 95 in the back here. Now the ear bars are not comfortable, but it depends on not putting them in too far. And what I told Mark here, our cooperative patient, is that we're going to use this temporarily just to be able to anchor the ear bar. And the reason that it's uncomfortable is not because putting them in the ear bar directly, but when you attach the frame and you begin to use some activity to anchor the pins, it torques the frame a little bit, torques the frame on the ear bar, and that can be a little bit uncomfortable. So what we're going to do is we're going to start out over the patient's head. It's going to come over the nose here. Mark has sort of an average European style head, which is sort of more European, a little bit longer in the y-axis than in the x-axis. And no Asian head. So this is going to go in just temporarily into the ear canal. I told Mark that we would not try to make the ear bars touch each other. And so we're trying to get a relatively neutral position of where this is. Now, if this is in the ear canal, we'll be able to rock this frame like this. And why is that important? Well, in order to not only know what types of pins, what type of posts to be able to use, we're going to have to know if there's any prior procedures, prior surgery, prior craniotomy, prior shunt. So we're going to know about all of those things in advance, because that's going to determine where we can anchor a pin. Now, while we're here, I'm just going to this temporarily in the ear, we're going to be thinking a little bit about what type of pin sizes. We're going to use anesthesia. We're actually going to inject anesthesia with a needle right through this and to be able to the scalp, usually about 3 to 5 cc's. We're going to take this pin to size based on this post. These pins cannot come out below the base frame here, because that runs a collision risk not only with the gamma knife, but it also runs a collision risk with the coil from the MRI unit. So each pin is going to be adjusted based on just having it come out from the little plastic insert, and it's going to be tightened down. When we tighten this down after we injected the local anesthetic, we're going to actually do this from one side versus the other. So I'm going to give you a post here. We're going to pretend that you have a pin, because Mark didn't really want to have a pin placed. And we're going to tighten. He's going to tighten the one in the back, and I'm going to tighten the one at the front when the time comes. And this one's going to actually send this post out a little bit like this. It won't happen in the back. So the tension on the pins is very important, and once we have this anchored and the tensions are quite good on the pins, we'll take the ear bar out, and then we're going to actually move Mark and the frame together, and the frame must move with the head, not on the head. It's an occasional situation where a patient's got a craniotomy here from surgery, in which in essence there's very little orbital rim here anymore. And in that situation, it's actually possible to put the frame on with maxillary fixation, which means placing a pin underneath the eye here in the maxillary bone, But this requires more careful attention to local anesthetic injection into the fascia and tissue here to anesthetize that. So those are some of the frame pearls that we have learned over 17,750 patients. We, of course, do patients that are eligible for mask. We do that as well. But believe me, if a patient tells you in their office that I'm claustrophobic or I can't have an MRI scan without sedation, in my view, not many of those patients will be able to have a mask procedure.